Hi, I'm Susan Taylor with Scripps Health in San Diego, California. This is something most folks don't want to talk about, but not talking about it actually could really put your life at risk. It could jeopardize your life. We're talking about colon cancer and rectal cancer, colorectal cancer as we group it together. Now, I know that getting a colonoscopy is, well, it's kind of got the ew factor, right? But actually, according to the American Cancer Society, colorectal cancer is the fourth most common cancer diagnosed in the United States, and it is the second leading cause of cancer death. About 50,000 people are expected to die this year from colorectal cancer. So having that conversation with your doctor could in fact save your life, because this is often a very preventable disease. Joining us today to talk about this is Dr. Walter Coyle, who is the head of gastroenterology at Scripps Clinic in La Jolla, California. Thanks so much for being with us,
Well,
Doctor.
Thank you for having me.
So colorectal cancer affects how many people each year?
It's about 140,000 between colon and rectal cancer, and about 50,000 of those will die this year in 2018.
As we said that, and so what are the symptoms? What are the signs and the symptoms?
Well, the most common symptoms are none. We actually find it by screening now. But if you're having symptoms, it'll be bleeding, usually from the rectum, be bright blood. There can be bloating. There can be a change in bowel habits or pain that's come, and not just for a day or two. This has usually been going on for several weeks, and then that's when you should seek out attention from your doctor.
So when you say change in bowel habits, what do you mean?
It can be you used to be regular and now you're having constipation, or now you're having diarrhea, or now it's alternating back and forth, and it never did that before.
And so how long does that go on before you should go, oh, this is something really to take a look at?
What happens to all of us sometimes when we travel or get infections, but this is going on for weeks or certainly over a month. You should seek out your doctor's attention unless it's bleeding. If there's significant bleeding, seek your doctor's attention right away.
So how do you, that's the question, is how do you know if it's something serious? Because let's say you're eating a bunch of bananas, or maybe you've changed your diet and you're on a high fiber diet, and so that's causing you to go to the bathroom more.
Well, if it's a day or two, I wouldn't worry about it.
Okay.
If this is a dramatic change for your pattern that's new, then I think you at least talk to your physician about what's the next step.
And you say talk to your physician, you say go to a primary care doctor, or do you need to go see a gastroenterologist?
I think primary care doctors are very good at sorting this out. And they look at your screening. Have you been screened for colon cancer? Do you need to be? And where's your age in that zone? And we can talk about colon cancer in young people later. But, it sometimes does need a test at that point.
Who's at risk for getting it? Is it men more than women, women more than men?
Well, it's actually about equal for the death rate for men and women, but women are protected while they're still having their periods from estrogen. So women get it about 10 years later than men, but they catch up. So at the end, men and women have the equal death rate from colon cancer.
So what are the risk factors for getting colorectal cancer?
Well, we sort of sorted out there's environmental and there's genetics, like in most of the diseases. The big ones is smoking is a huge factor, being obese, not eating lots of fresh fruit and vegetables, a diet that's higher in red meat, particularly processed red meat. So I love bacon and sausage, but not every day, maybe once a week, at best. And then also, we think if you're active, that makes a difference, which also goes with the obesity factor. And then
if you're active, it makes a difference for it protects you against it?
Just being active decreases your risk for colon cancer. But it probably goes to also you're less obese when you're that. And especially the fat that men get, the fat that's in the central area, that's one that's probably more cancerogenic than other ones.
And what about family history?
Well, that's huge. You can have a family history that's very strong. 5% have very strong family histories, but they're different than we're talking today. But most people have a mom or a dad or an aunt or an uncle. If they've had polyps or cancer, it can double, triple, even quadruple your risk to get colon cancer. So it's important to talk to mom and dad and brothers and sisters. Hey, what'd your colonoscopy show? Because the worst thing is not to share that information, because if they have a family history of colon cancer, or they have colon cancer, you now have a family history and might be able to be screened sooner.
Huh. And what about different ethnic groups?
Well, we know African Americans have a higher rate. In fact, several societies have now said we should start screening African Americans starting at age 45, and that's both male and female.
Really? Mm-hmm. Huh. So how do you screen for colorectal cancer?
Well, the big thing about screening is just getting a screening test done. I follow the guidelines that came out of last year that go tiers. There's 3 separate tiers of screening. Tier 1, which I consider the best, is colonoscopy and the test called FIT testing, which is a stool test that looks for blood. Tier 2 is the CT colography. Some people call it the virtual CT, the stool DNA test, and then a short scope, the flexible sigmoidoscopy. And Tier 3 is the capsule. And that right now it's only FDA approved if you failed a colonoscopy, and that's why it's Tier 3.
So the capsule, that's actually what? It's a capsule that you take and it has a camera in it?
It has a camera. It takes about 40,000 images as it travels through your gut.
Wow.
But the problem is the prep has to be even tougher than the prep for a colonoscopy. There can't be any stool in your colon at all. So it's a 2-day vigorous prep, and it can still miss things. But it's better than nothing. But I actually rarely order it except for the person who can't physically have a colonoscopy.
Why couldn't someone physically have a colonoscopy?
They're just too ill. They have certain anatomy that makes it non-conducive, or they are just scared of having a colonoscopy. Like I said, a screening test is the one that's good that gets done. And so those people, I usually use DNA test or the stool fit test. And I prefer the fit test because it's almost as good as the stool DNA test, but it's much cheaper. It's about $25.
But explain what exactly is the fit test?
So it's fecal immunochemical. So it's really a cool test. Before they would actually check for blood in your stool, and if you had a lot of red meat or stuff like that, it could make it false positive. This actually checks for human hemoglobin. Hemoglobin is heme plus globin. This specifically checks for globin. It's very specific to humans. Doesn't matter how much red meat you have. It's a one-time test. You can do it and you can mail it back to your doctor's office. It's just a little smear on that. It costs about $25. Very good at detecting colon cancer. Not quite as good as detecting polyps, but it's good for detecting it. So it's a good test to screen.
But it's not as good as the colonoscopy.
Right. It can miss about 15% of colon cancers, where colonoscopy hardly misses any colon cancers.
All right, so we've got some animation and some video about the actual colonoscopy. Why don't you explain what that entails? Because as I said at the beginning, everybody's got the ew factor about a colonoscopy. So just go through the actual procedure for us.
We can talk about prep later, but the colonoscopy, you come in and we sedate you. So you're very relaxed. We give a combination of a Valium-like drug and a weak narcotic. And that combination makes you very relaxed. Most people don't even know they've had the test and they wake up, oh, it's over. Some places are using a medication called propofol, which you're completely out, which essentially is general anesthesia. And that's very safe also. And then the scope's about the size of my little finger. Okay, and then we go around all the way to the end of your colon, which is over on the right side of your body. And on the way out, we look very carefully for polyps. And polyps, you say, what's a polyp? Think of me as a dermatologist of your colon. I find lumps and bumps and moles and things like that. If I see anything that doesn't look natural, I take it off. And we call it a polyp. But some polyps are precancerous and some aren't. And then the whole test takes maybe 12 to 15 minutes if there's no polyps. And every polyp takes about a minute to take off. So sometimes it takes 20 minutes to do it all.
And so do you then test the polyps?
So we send it to the lab in formalin usually, and they look at it and tell us what kind of polyp it was, what the risk was. Occasionally, it'll have cancer in it. That's very unusual though. But we've cured the patient. If it's a small polyp with cancer, we've cured them just by doing the colonoscopy.
And so you take the polyp out and they don't have to have any follow-up chemotherapy or anything like that?
Correct. And then we often then go back and look sooner though, if you've had a polyp that had cancer in it, to make sure we got the whole thing out and to make sure it's not other ones.
If you take a polyp out, does it automatically mean that the polyp is precancerous? So if you left the polyp in for X number of years, that it would actually develop into colon or rectal cancer?
Only about half. Half the polyps that we take out are called hyperplastic. And it's like the little skin tags people have in their neck and armpits. They would have never, ever gone to cancer. But the other ones are adenomas. Those are precancerous, and if we had left it in there, it could have become cancer. And we're not that good yet to say, oh, this adenoma would never go to cancer. So we take out all the adenomas and all the polyps. And we think most of them over time would have become cancer if you lived long enough or the polyp lasted long enough. But some polyps probably would never turn to cancer, but we can't tell. It's like the dermatologist. He takes off a lot of things off your skin that would have never become melanoma to prevent that one melanoma.
But if a polyp is found and it's taken out, does this still put you at increased risk down the road for getting colorectal cancer?
If it's a hyperplastic polyp, no risk at all. We keep normal screening, which is every 10 years for colonoscopy. If it's an adenoma, yes, it does increase your risk, and then we shorten down the interval for screening to 3 years or 5 years because you grow new ones. I call it picking the weeds. I go in there, and each 5 years, there's more polyps, and I just take them out.
So we want you to hold this thought because we'll come back to you in a couple of minutes. But at what age should you start getting checked for this, for colorectal cancer? I know that traditionally, and we briefly discussed this a couple of minutes ago, that it's age 50, but there's been some new studies out which say maybe it should be age 45 because there's been a spike apparently in colorectal cancer in younger folks. So we'll come back to that in a couple of minutes. So just hold that thought. Can you tell us the difference, please, between a colonoscopy and this flexible sigmoidoscopy?
It essentially is 1/3 of the bowel. The flexible sigmoidoscopy goes up to about here. Sometimes we cross here, where the colonoscopy does the whole colon. It's a good test. It saves lives, decreases colon cancer. Canada is relying heavily on flexible sigmoidoscopy and FIT testing. However, I sort of view it like a mammogram. You're doing a mammogram on one breast, and you're assuming that with that one mammogram tells you what's going on the other side. And that's not necessarily true. So gastroenterologists as a society and the American Cancer Society think colonoscopy is the better test. But flexible sigmoidoscopy is no sedation. It's safer that way, but it can be inconvenient too. And you still have to prep for a flexible sigmoidoscopy.
Let's talk about the prep.
Oh, everyone's
because everybody's, that's the favorite part of getting the colonoscopy. Explain exactly what the prep is for it.
Well, it's gotten a lot better. Let's put it that way. It used to be that gallon stuff, and we have these people, I go in, they'd be sitting there trying to drink this gallon of stuff, and it's deflating. It's now split prepping. So even if it is the gallon, it's a half gallon, then a half gallon.
A half gallon of what?
It's a liquid that tastes like salt water that lavages you out.
What does lavage mean?
To clean out. It's essentially wash that. It's not a true cathartic where you get cramps. It's a laxative to get you going. So it doesn't cause a lot of cramps. But a gallon by anyone is hard to drink. So now they develop low volume preps, and there's several in the market, and they're about 8 to 9 ounces, and then you do another 8 to 9 ounces 4 or 5 hours later. But the effect is the same. You're still going to poop 10 to 15 times, but there's less cramps, tastes better, and you can drink whatever you want. Gatorade and tea and ginger ale and stuff like that. So it actually is much more palatable, and people are finding it's not so bad.
So let's say I'm having a colonoscopy in the morning. Mm-hmm. I take this, the half gallon, and I drink it at what time?
Well, it depends. I don't usually use the half gallon. I use either a half gallon prep now or the low volume. So you would take half of the prep, usually around dinner time again, and then we like you to take the second half 4 to 6 hours before the colonoscopy. So that's the new problem patients don't like because it's the split prep. So we actually have you wake up. If you have that 8 o'clock appointment, you're supposed to wake up like at 4 and finish the rest of it. Then, of course, you'll have to go to the bathroom in an hour or so. But if you have an afternoon prep, you take it in the evening, and then when you get up in the morning, you take it again. So it's an advantage.
So if you take it in the evening, and basically you obviously you're not having any dinner, you're having this liquid.
Right.
And then you're going to go to the bathroom for approximately an hour or two.
Couple hours, right.
Okay. And then you're settled down and you can go to sleep.
Right.
So you will have a normal sleep that night.
Pretty much.
Pretty much?
You might have to get up to go to the bathroom. Everyone's different, but most people do get a reasonable night's sleep.
Okay, and then you get up in the morning, let's say, and you take the other half of the prep, and then you're sitting up, going to the bathroom for another hour or two.
Yes.
And that's pretty much it. But you can drink as much as you want all during this time as well.
We have you stop drinking all clear liquids when you finish that prep 4 hours before. That's the last liquid you can drink. But up to then, I want you drinking as much as you can. I tell patients, I want you peeing as much as you're pooping. That way you don't get dehydrated. The problem when people get dehydrated, they get the headaches and feel lousy. But if you're drinking whatever you want, broths or things that have salt in them, you feel okay.
And you still, do you feel hungry during this time, or because you're so loaded up with liquid, you really don't feel
Well,
hungry?
I worked the day before my colonoscopy, and I found they have these juices that are now like clear grape juice, tasted great. I could still drink ginger ale and 7-Up, so I did fine. And yes, I really wasn't hungry because I was drinking a lot.
And then after you have the colonoscopy, how quickly can you start to, have a normal diet again?
As soon as you're done, you go eat. In fact, people always ask me, can I eat now? Can I go? I said, just don't go to Old Country Buffet and put 2,000 calories down. Have a nice meal and go home.
And what happens if you end up with colorectal cancer? What's the treatment?
Well, the survival has gotten dramatically better. And also we're finding now more people are not getting colon cancer, which is good in the 55 and older group. We can talk about that younger group in a second. So usually it's surgery. If we find a polyp that I can't take out, We're going to cut out that segment of the bowel, and they'll take the lymph nodes that are around the bowel, and based on that, we decide you need further therapy. If it's very superficial and no lymph nodes, we won't go ahead and do anything else. If there's any lymph node involvement or it's spread, then we will usually add chemotherapy to that. The exception to that is rectal cancer. Because the rectum is fixed at the bottom, we actually can give radiation. So we can give chemotherapy radiation beforehand, shrink it down. Sometimes the cancer is gone, but we still operate. So the cure rates are higher for rectal cancer for the same stage as regular colon cancer. So it's very exciting, and so we've really made huge headway in the last decade or so.
So what is the survival rates?
All comers, it's about 65%. 5-year survival. That's how we do 5 years. Are you alive at 5? Essentially for colon cancer, if you go past 2, you're probably cured. Okay, but it's 5 years. But if you find it early, which is the right of screening, 90% 5-year survival. So we cure 90%. If you wait and present when it's already spread, it's 13% 5-year survival. So it's huge. That's why screening is so important. Even if you have cancer, we can still save your life.
All right, so we talked about this a couple of minutes ago, so let's come back to this thought. Traditionally, the guidelines have been to start checking for colorectal cancer at age 50. You're saying for both men and women, but now the American Cancer Society came out not so long ago and said, no, actually, we think we should start screening at age 45 because younger people seem to be getting colorectal cancer. There's a spike in that. So why the spike for younger people, and when should you start getting screened?
Well, we did a study at Scripps. We looked at our last 2,000 or so patients with colon cancer, and we looked at the ages. 10% were less than 50. So and that sort of matches the national average. So then we tried to look at why. Were they heavier? Were they smokers? Do they have family histories? Nothing came out that separated them out. So it's very frustrating. We think something in the environment has made them more prone to get this, but we can't figure out what it is right now. So there's a lot of science going into that. So having said that, the American Cancer Society did a modeling exercise saying if we move screening down, could we save lives in those 10%? And what's concerning is the mortality has gone up in people under 50 for colon cancer 11% in the last 10 years. And that's what they're trying to stop. But it's a problem because you do a lot of extra colonoscopies in people that wouldn't need it. So we've tried to decide what to do. So they didn't put any restrictions on what kind of screening to do. They said, just consider screening 45. It's a qualified recommendation, not a mandatory or a strong. So what I'm going to recommend right now is patients age 45 get the stool test, the FIT test. You mail it in. If that's negative, you can feel good. Get that every year. And then I think the regular guidelines would say FIT test or colonoscopy 50 would happen. And of course, if you have any symptoms, you immediately should get a colonoscopy if you're 45 or older.
But younger folks, is it the spike in younger folks getting colorectal cancer because they're not going to the doctor to be checked for it?
We've looked at that. I think, is it doctors not thinking about it? Or is it the patients staying at home and not going in because they were too busy? We're not sure.
Or they think I'm too young to have these symptoms,
that's the thing.
or maybe symptoms or something else? Or?
It could never happen to me. I hate that line. I didn't think it happened to me, and I ignored. I was having bleeding at my bottom for 6 months. Well, get to your doctor and get it evaluated, right? Those are the things. You ignore those things, and sometimes you'll go false alarms to the doctor, and your primary care doctor is fine. They're very good at sorting out, I think this is just a hemorrhoid. I think we should definitely do a flexible sigmoidoscopy or a colonoscopy.
And in addition, there was a national study that was published in the New England Journal of Medicine found that a 53% lower death rate from colorectal cancer among people who had a colonoscopy and a precancerous polyp removed compared to the general population. And they're saying that many patients were followed for 20 years in this study. So I guess the bottom line is the colonoscopy can save your life, right? But you're saying, was it only about 60% of the people who should be screened for colorectal cancer actually have the test? Is that correct?
Well, unfortunately, they were trying to there's a big push by all the societies to get 80% of people eligible screened by this year, 2018. It's 80% for 18 is the logo. But the problem is people still avoid it. Even just the stool test, just mail it in. How hard is that? For the cancer, it's the number 2 killer of people, men and women. So it's a shame if you don't get screened. Yeah, I get the idea. I don't have the time to do a colonoscopy. I don't want to prep. Then just give me a stool sample. If that's negative, we're good to go. But the other side of that coin, if it's positive, you really need a colonoscopy because that means you could have colon cancer.
And the trade-off is what? 12 to 24 hours of a little discomfort, and the trade-off is
life or death.
Save your life.
Right.
Yeah. Any final thoughts, Dr. Coyle?
I think the important thing is you take care of how people get their cholesterol checked. Women are very good at getting their mammograms. I put this in the same level. It's a cancer that kills people. It's very easy to prevent. And then also healthy lifestyle. People ask me, what can I do? The one thing we didn't mention, the other societies have said a baby aspirin. I reckon for my older patients with polyps, a baby aspirin decreases your chance for getting colon cancer. But a healthy lifestyle, people get tired of hearing the doctor say, stay thin, exercise, don't smoke, watch the alcohol, and avoid red meats, and eat lots of fresh fruit and vegetables. That's the best thing for all cancers, particularly colon cancer.
Dr. Coyle, thanks so much for taking the time to be with us.
My pleasure.
We
Thank you.
appreciate it. Scripps is ranked by U.S. News & World Report as among the nation's best in gastroenterology. If you'd like more information on colorectal cancer and how to prevent and treat it, just please click on the link or go to scripps.org/videos. If you want more critical information about your health, we take care of you from head to toe. Please subscribe to our Scripps Health YouTube channel and follow us on social media at Scripps Health. Thanks so much for joining us. I'm Susan Taylor. It's our mission at Scripps to help you heal, enhance, even save your life.